Okay, I'm recording now. Okay, so
Thank you very much. Okay.
I present you Dr. Carvallo. He was the head of a hospital in Buenos Aires province in Argentina. As far as I know, he's the first doctor to start who started applying ivermectin in the world only 3 days after the publishing of the Australian paper. And he started developing different protocols. Two protocols are prophylactic, and another one is for treatment, inpatient treatment. He's published already, and he's being cited by papers from the United States and even in Europe. And well, he's probably one of the doctors who knows more about ivermectin and COVID in the world. so he could, I give the microphone to him so he can start explaining everything to you.
Okay, thank you, Freddy. Do you listen to me? Can you listen to me?
Yes, we can hear you. Thank you. Yeah.
Okay. Well, so we'll start showing you. Please let me know if something is not understood or if something is
Okay,
not clear. Just stop me. Okay, as Professor Nazar said, we started working with ivermectin and COVID-19. Truth to tell, I think that the people, the medical doctors who know more about ivermectin are the African doctors, because in Africa it's been used against onchocerciasis and other parasites for many years. So if there is a group of doctors who know more about ivermectin, I think it's you, not precisely us. But the fact is, we did all the research with Professor Hirsch from the Hospital Muniz, which is the most important hospital dedicated to infectious diseases in Argentina. First of all, when the pandemic broke out, we started watching on what was going on the northern hemisphere. But at that time, we thought that the virus was affected by the temperature. I mean, temperature could affect the virus aggressiveness, something which is absolutely wrong. But in those days, a year ago, we thought so. So we stopped watching at the northern hemisphere, and we started watching to what was going on in our same latitude. This is Argentina, this is the south of Africa, and this is Australia. So we started seeing what they were doing or what they were not doing. And that's how we came across with people from the Monash University who had just a preprint on ivermectin usefulness on COVID-19. Truth to tell, they have been studying ivermectin in vitro against other virus, against dengue fever, against West Nile encephalitis, and at that moment when they were studying that, the epidemic started. So they shifted their studies from those viruses onto COVID-19, and they found out that they could reduce dramatically the viral load in less than 24 hours in vitro. We came across the preprint before it was released, and we thought that it could be applied very simply on human beings because we have been using ivermectin not for onchocerciasis. We don't have onchocerciasis in Argentina, but for strongyloides, stercolaris, and other enteric parasites, and also for scabies. So pediatrics and infectologists and dermatologists and gastroenterologists in Argentina are very well accustomed to using ivermectin. So it's not a drug that was unusual for us. So we made two protocols and we submitted them both to the sanitary authorities from the hospital, and also to the National Library of Medicine in the United States, and they were included in the clinicaltrials.gov. The two protocols were, as Professor Nazar mentioned, one for prophylaxis and one for treatment. The prophylaxis was by using, there were two different ideas, and that carried out to be two different trials, one with ivermectin alone, which was called Iverprev, and the other one with ivermectin plus carrageenan, from which I will talk a little bit later. This was called Ivercar. And for treatment, that is for people who had already contracted the virus, we had a protocol with ivermectin, dexamethasone, enoxaparin, and aspirin. We made an acronym from all the drugs that were involved in this protocol, and it was called IDEA. Well, this is not precisely the order in which we use it, but it sounded better this way. And also, now that dexamethasone is widely accepted all over the world to treat COVID, remember that we started using it in February last year, when the recovery study from England had not yet even begun, and nobody accepted to use dexamethasone in those days. And we started using it because of the hyperinflammation, which I will talk about a little bit later. What are the ivermectin mechanisms of action? We don't have to apply to the mechanism of action that ivermectin has on the parasites, because it blocks the GABA receptors. Forget about this, because that's for parasites. We are talking about the virucidal effects. The virucidal effects can be divided into direct and indirect. The direct effects may be extracellular or intracellular. The most well-known, and the one that was mentioned in the first studies at Monash University in Australia by doctors Cayley and Wastaf, was this one, intracellular, by blocking the alpha beta 1 importin that enables the virus to reach the nucleus of the cell. That is the most well-known, but there are other effects. For instance, there is an effect which is extracellular by making small holes on the lipoprotein nucleocapsid of the virus. These holes are called ionophores, and through them, hydroxyl compounds can enter the virus, so reducing its effectiveness of to infect, its infectious efficacy. And talking about the indirect effects, there's one as in
I like to
immune modulation.
interrupt for a second.
Sorry,
We're not seeing,
no problem.
You had a PowerPoint presentation, you told me. Maybe you want to show it?
I actually I am showing the PowerPoint. Can you see it?
I'm not seeing.
No, we can't see the PowerPoint, Professor.
Oh, sorry. I thought you were watching it. Not okay. Well, let's go back. Just a minute. Professor Nazar has to, that's why you couldn't see it, because you disabled me from screen sharing. You have to enable me to do so. It still says host disabled participant screen sharing. Freddie, you have to allow me to screen sharing.
Professor Nazar, is it possible for you to enable
Oh wait,
Professor Carvalho
I think I can do it now. So now you can see it.
On your behalf, I got in contact.
Can you see it now?
The thing that I love about your email.
Yes, now we can see it. Thank you.
All right. Well, this is the first slide, which are photographs, so you lost nothing. And this is the latitude from Argentina, South Africa, and Australia. This is the connection between the Monash University, which I mentioned, with a Ezeiza hospital, in which we developed the studies. These are the two protocols from prophylaxis and treatment that I already mentioned. Don't worry if I go fast, because we are going to go back as many times as necessary. And I was right here with the intracellular effect by blocking alpha beta 1 importin, and the extracellular effects by making ionophores, that is by allowing hydroxyl compounds to enter the virus and reducing its aggressiveness. And the indirect effects are by immune modulation, because ivermectin has proved to interfere between interleukin 6, interleukin 8, and interleukin 10, so reducing the immune response. And it also stabilizes the endothelium. We have learned that this virus provokes an endothelitis, and that endothelitis, that disruption of the endothelium of the vessels, provokes the platelets to group together to form thrombus and to cause emboli that can affect any organ in the human economy. By stabilizing the endothelium, it reduces that risk. And it also makes, it makes a prolongation of the prothrombine time. If this virus causes the most severe cases, and even the fatal cases, by hyperinflammation and hypercoagulation, the fact that it reduces, vermectin reduces itself, both effects, is a real blessing in disguise. And now talking about the carrageenan mechanism, it's a seaweed, the carrageenan, which is used mostly in gastronomic business, but also in medicine, which is used as a thickener, something to thicken compounds, pastry and things like that. It has a direct effect by opposite electric cargos, because carrageenan has a negative cargo and the virus capsid has a positive cargo, so it adheres to one another like a magnet on the door of a refrigerator, and so wrapped, the virus cannot be so aggressive as if it was left alone. And the other indirect effect is by competition of receptors. The IDEA protocol is intended for sick people. We made our own division with minor criteria, major criteria, and combining them, we have three different kinds of cases according to severity. Mild cases, which are outpatients, moderate and severe cases, which are inpatients, they have to be admitted. And don't worry about the contents, because I'm going to lead this to you. And Dr. Ibuta, I will leave it to you, so you can use it as if it was yours. Okay?
Thank you very much. I really appreciate that.
You're very welcome. And that's how we came to the way to treat the patients. Those confirmed mild cases and their close contacts, we have to emphasize the fact that we have to act on close contacts. Otherwise, we will never stop spreading the virus. And we use it 24 milligrams per dose, that is orally, in a single dose to be repeated a week later. We don't use corticosteroids in these mild cases, but we do use aspirin 200 to 250 milligrams orally on a daily basis as an anti-aggregant to reduce the aggregation of the blood, just for prevention. These patients are outpatients, as I already mentioned. The moderate clinical stage is treated with 36 milligrams of ivermectin we keep using aspirin. We add dexamethasone 4 milligrams, and we also, as they are admitted at hospital, we use low flow oxygen or oxygen concentrator. And in the severe cases where bilateral pneumonia, we use 48 milligrams of ivermectin. Now we change the aspirin for enoxaparin. We keep using the corticosteroid, and we put the patients into invasive ventilation, that is mechanical ventilation.
You get me my earphone. I don't have to call you.
So we had to confront this treatment with the other treatments that were used in those days. That is lopinavir, ritonavir, hydroxychloroquine, and remdesivir, convalescent plasma. And we found out
Dr. Carvalho,
yes.
I think is Professor Nazar, is he the co-host? Please, can you mute people's mics because they're really disturbing, there's background noise.
Well,
Please block the people who are making noise in the background. Thank you.
Okay.
And everybody, please block your mics, mute your mics.
Dr. Carvalho, I made you a host, so you have to do that, please.
Well,
or make me a co-host.
Oh, yeah, it's kind of difficult, isn't it? Remember, I'm an old man.
Okay.
Where did you find it to mute the other people?
It's all right. It seems like they've kept quiet now. Please, everybody, remember to mute your mics.
I find it absolutely quiet. Well, thank you.
Yes,
so let's go on.
It's quiet, but before it was not. Yeah.
We made a comparison between our treatments and the other treatments that were used in those days, and we found out that our treatment reduced mortality 7 times if compared with all the other treatments put together. That is, we didn't make a comparison with placebo. We made a comparison with all the other treatments: hydroxychloroquine, lopinavir, ritonavir, remdesivir, and convalescent plasma, and everything that was available in those days. And we proved a statistically significant way that we reduced the mortality rate 7 times. 7 times. And talking about the mild patients, that is the patients that were outpatients, we know that about 10% of the mild patients, when already diagnosed, in the following days, maybe in the following week, will get worse and worse and will have to be admitted. We studied 135 patients with positive swabs, but minor criteria, so no need to be admitted, with an average age of 53.5 years, and the medication that I mentioned for mild cases, that is ivermectin 24 milligrams oral, to be repeated a week later, and aspirin 250 milligrams orally on a daily basis, and the need of ulterior admittance was 0. That is, no patient had to be admitted. They could be, they were free from virus in less than a week, and they remained in their houses.
I bring the body down.
All right, and now talking about the other protocol, the protocol for prevention, we started 2 groups. One group with all the PPEs that are available and in use all over the world, and we added the ivermectin, and the other control group from 98 patients, healthcare personnel, and we followed them with swabs, rhinopharynx and oropharynx swabs performed on a weekly basis for a whole month. And in that month, 11 from the 98 group that didn't use the protocol, 11 healthcare workers contracted the virus, while no healthcare worker from the 131 who were working and using the protocol, no one, I said, contracted the virus. These groups are perfectly comparable because they are all personnel who were working in the trench, that is in the front line of the virus fight, in the emergency room and dealing with COVID patients 24 hours a day. So this was quite different. And the difference between the ones that used the protocols and the ones that didn't use it. Of course, the ones who were more affected in the group that didn't use the protocol were the nurses, not because of neglectness, no, not at all, but because the nurses are the ones who remain longer with the patients, far longer than we doctors. And then we spread this protocol to 3 hospitals, and we counted on 1,195 healthcare workers. We divided them into 2 groups, one about 800 healthcare workers who use the protocols, and the other one, 407 healthcare workers who didn't use it. And we followed them in the same way with weekly swabs for over 60 days, almost I'd say 90 days, really. And we found out that more than half of those who didn't use the protocol contracted the virus, while not a single one using the protocol contracted the virus. And that's quite the difference. Those 2 protocols were presented at the National Library of Medicine, and I will leave you the numbers for you to check them if you want. And the other protocol, the protocol I mentioned of prophylaxis, was used combining carrageenan and ivermectin. But in the meantime, another protocol called Iverpre protocol, only with ivermectin, was performed at the Moniz Hospital, and 162 healthcare workers received ivermectin alone on a weekly basis, 8 weeks, and then 4 months of rest, vacation, as you prefer to call it. And none of them contracted the virus. And most of these doctors and nurses and healthcare workers are now starting or have already started the second round of ivermectin, the second round of 8 weeks of ivermectin. Why do we use 8 weeks and then we stop? Not because we are fearing an overdose, not at all, because doses far higher than this have been used in the past. But the fact is, Dr. Hirsch proved in his hospital many years ago, working on Norwegian scabies in AIDS patients, that using ivermectin on a weekly basis for 8 weeks, the ivermectin started remaining in the fat tissue of the patient, and that gave the patient an extra duration of the effect of ivermectin for over 4 months longer. And that's why he used that in the past, and we repeated the successful treatment in the present. That was for Norwegian scabies in AIDS patients. This is now for COVID patients. Well, these are some of the meta-analyses that were made all over the world. This is not made by us, but we are mentioned in some of these is the trials. And there are now 46 trials submitted to the National Library of Medicine in the United States. And 28, about 30 now, have been finished and the results have been published. All of them have reported positive results with ivermectin. This is a kind of a tricky figure because it says, well, this is absolutely magical because 100% successful. No. This means that all 100% of the trials proved the effectiveness, but with different degrees. We proved that it was 7 times better than all the other medicines. Some others proved that it was 5 times better. Some others proved it was 3 or 4 times better, but all of us proved it was better than all the other medicines. And when they crossed all these studies in order to find out if there was a bias, there was a chance of mistake in the studies, they found that the chance of a bias in these 28 studies was 1 in 268 million. That is absolutely nothing. The first time we tried to publish our studies was in the Journal of American Medical Association. That was April 9th, and they didn't pay attention to us. Maybe, well, I don't know why, but because we were talking about corticosteroids, but that it was a kind of a bad word in that moment. And they said, the editor-in-chief of the magazine said that, well, they didn't consider this a priority. Okay, we were not discouraged. We were disappointed, but not discouraged. And since then, we have published all our results in Spanish language, these 3 ones, and in English language, these 6 ones. This is a preprint from MedAxive, so it's not peer reviewed, but all the other studies have been peer reviewed, and well, they have been accepted. That's why now ivermectin is used worldwide. And we had a summit on ivermectin in France, and there were people from Africa, from Europe, from Asia, and North America, and South America, and Australia using ivermectin, all with good results. And that's why, in spite of the lack of attention that the big pharma has given us, because it's so cheap that they are not interested in this kind of medicines, we have to keep fighting in order to provide our patients with a better way to surmount this pandemic. And that's why we have to behave like kites. The stronger the wind against us, the higher we must fly. And this is it.
Okay,
Thank
great.
you very much, Professor Carvallo.
Okay.
Anybody has questions?
Thank you very much for that wonderful presentation.
With some troubles, you see. So it's not only you, Ivyuta. I made a mistakes with a Zoom meeting. So we made mistake with the Zoom meeting, but it's okay, provided we try to work together.
Yeah. The question that I had was, what was your criteria for mild, moderate, and severe infection?
Yes, for yes. Well, for the minor criteria were when the saturation was not completely affected, that is no less than 94, and the fever was mild, moderate, no more than 37.5 degrees Celsius, and where there was a minor rash, and when the episodes of the diarrhea were scarce, and the hypogypsia and hyposmia, we consider them minor criteria. They are very suggestive of COVID, but they are not suggestive of severe COVID. On the other hand, when there are many episodes of diarrhea, when there's giant urticaria, when the blood concentration of oxygen is really affected, when there is bilateral pneumonia, when the fever is over 38 degrees Celsius, we consider them major criteria. It was there in the graphic, so I leave it to you. It's all divided. You may say, but if we already have the criteria from the WHO, from the World Organization, why do we create our own criteria? Because we found them easier to understand, easier for the doctor who is working in the trench, not to memorize so many things. And besides, I regret to say, but I have to say that WHO hasn't been very accurate in its work up till now.
Thank you for that. Another question that I had was why we know by now that this disease has been very politicized.
Absolutely.
And the big pharma doesn't want anything to do with these cures which have been found because they can't patent ivermectin, they can't patent the chloroquine and those other drugs. So what do you think is the way forward for us? Because now the news that we have is that our government has ordered all the vaccines already, and they're hoping to have rolled out the vaccine. Obviously, there is a conflict of interest because they want us to roll out these vaccines, and yet there's no need for the vaccine. Or is that coming in the next talk?
Well, you know that all the vaccines have been developed in very quickly, and sometimes velocity, speed, is not a good thing when applied to research. I mean that the vaccines have been widespread all over the world, and the one who reaches the goal first will be the winner and will be a millionaire. And as you already said, ivermectin and many other repurposing drugs don't have a patent because the patent has expired many years ago. So they are not interested in this. As Dr. Pierre Corey exposed in front of the senators at the United States, at Washington, D.C., Big Pharma is interested in new and expensive drugs or vaccines instead of repurposing drugs that would be fine to cure a lot of people, to reduce lethality drastically, dramatically, and also to act as a vaccine itself. Because talking about immunity, immunity is the efficacy of avoiding an illness, okay? The immunity may be natural or artificial, and may be passive or active. The natural active immunity is acquired by getting ill, and the artificial active immunity is achieved by receiving a vaccine. Which of the two is the most effective? Of course, getting ill, but but you have to live to survive. You have to survive the illness for that. And with ivermectin, we can make sure that people who get infected won't get severely infected. The period of illness will be shortened dramatically. The severity will be reduced dramatically, and we can achieve to herd immunity without many casualties in between. In Argentina, they have started using the Russian vaccine. The Russian vaccine has no phase 3. So we are the phase 3. We are the hamsters. And I don't think that's good. I'm not proud of that. It's not a matter of ego that I have been working on ivermectin. That's why I don't like the vaccines. I like all vaccines that prove to be both effective and safe. And effectiveness and safety has not been proved beyond doubt up till now.
Thank you very much, Dr. Carvalho, Professor Carvalho. We have some other questions in the chat. Dr. Wahome is asking, how long do you give the aspirin?
15 days, 2 weeks, 2 weeks.
Okay, then that's the second question is, what is the dose for the prophylaxis?
Well, talking about ivermectin, we have to say that the solution is better received by the body. It's more easily absorbed than the tablets. So if we are talking about the solution, ivermectin in solution, we use 1 drop per kilogram on a weekly basis. 1 drop per kilogram on a weekly basis. The tablets in Argentina have 6 milligrams. So what happens if we don't have the drops? Well, there are 30 drops in 1 tablet. So you may make the conversion. We prefer the solution for 2 reasons. First of all, we can personalize the dose as pediatrics do in the children by giving the exact dose according to the weight of the patient or the subject. And second, because it's better absorbed and more quickly absorbed. So the Tmax and the Cmax are reached far earlier.
Thank you very much. Another question is there an experience of long-term use of ivermectin and what are the side effects?
Well, as I already said, Professor Hirsch has been enrolling his subjects, the patients, so the subjects, because they are prophylactic treated, so they are not ill, for over 9 months up till now. 9 months, just the same as a pregnancy. And the side effects were very mild. A few episodes of diarrhea, some episodes of dizziness, and nothing else. We have not seen the encephalitis that is described like a Plum syndrome, that is possible lower encephalitis related to mectisan. We haven't seen that because it is a very, very rare side effect. And we have seen no other side effects up till now.
Another question, is ivermectin a good option for long COVID symptoms that many recovered COVID-19 patients experience?
Well, there are some colleagues in Argentina who are using ivermectin in long haulers. That is, the patients that take a long time to recover because of the brain fog, because of the chronic fatigue syndrome, and they have started using ivermectin in the post-COVID, and with success. I have not yet come across to their work. I will next week because we have a summit in Argentina with all the other doctors. I would invite all of you, but it will be in Spanish. So, but the results of that summit, I promise I will send to you after translating it. But this doctor has worked on the post-COVID and ivermectin, and he told me that he proved, I don't have the figures, but he proved that the long haulers find their illness shortened, and they recover far quicker than the ones who don't use it.
So the total duration, you had said something like 8 weeks, and then there's a break because of being able to store the drug in the fat tissue?
Yes, but as Dr. Hirsch has used it for over 10 months, there are subjects who have used 8 weeks, 4 months of rest, another 8 weeks, and then they are already resting again.
Then audio, you click it again.
Okay, Frederick, please can you mute your doctors? Mute your mics. Thank you.
I'm sorry, the problem is Dr. Carvallo is now the host and I don't have that power.
Well,
Okay.
I have the power. I have the power for once in my life. I don't know how to use it. Well, power
Okay,
is
so can we
power.
move on? Or somebody else has another question, or can we move on? Thank you very much, Professor Carvallo.
It's a pleasure.
Okay, so the next topic would be about vaccines. Many are very worried about the side effects. But let me show you two things first about ivermectin. Let's see if I can share the screen. Just a second. I need to share the screen. I need you, Dr. Carvallo, to here.
To allow
just a
you.
second. No, I'll try. Just a second.
You have the share screen in a green. At
Yeah,
the
I
bottom.
know. And you need to enable it. I can't do it. You need to.
So what I'm going to do is to
just name me a host. Just put your mouse on top of my image, and you see the 3 dots, and you make me a host, and that's it.
The 3 dots, the famous 3 dots, which I don't see anywhere.
On top, when you put the mouse on top of my image,
see, yeah,
you're going to see 3 dots,
which I don't see. Yes, I see now. I see 3 dots.
No,
and start video, rename, pin, spotlight for everyone, out profile, hide, self-view. Well, let's do this again. Ask to unmute, 3 dots. Ask to start video, rename, make host. That's it.
Okay.
Then the host, yes.
Okay.
Did I?
Just a second. Were you doing that on top of my screen or on top of my image? Because I don't have. Maybe it will take a second. Just a second. No, you should do that. Make host, but on top of my image. It's not working. I don't know why.
Oh, I see the 3 dots now, and say chat, pin, hide non-video, show self-view. But they don't give me the chance to choose Swift the host. Maybe so. Let's do something, Freddie. Now it's your turn to talk. I will leave the meeting so that
Somebody is saying that. Oh, so who is the host now?
I guess big pharma is.
No, actually, if I might just say something, there's a person called ASDS 987 Miracast that is now the host. If they can
so Professor Carvallo, you accidentally made AS Miracast the host. So if you want to, you just press